Moving on to the second topic in our talk, we're going to define palliative care. And I think the World Health Organization has a very nice definition of palliative care. They talk about the active total care of patients who have terminal illness, whose diseases will eventually end in the death of the patient. They talk about providing the best possible quality of life for both patients and families. The survivors of patients certainly need to be cared for within the paradigm of palliative medicine. And the World Health Organization recognizes that. This is the definition that we use in our EPIC-EM certification course. And I don't often read my slides, but this is a definition that I'll actually read for you. Palliative care addresses actively the physical, spiritual, psychological, therapeutic, and social needs of patients and families affected by terminal illness from the time of diagnosis of a terminal illness to death, as well as bereavement services for their survivors. So, palliative medicine is meant to address not only physical symptoms, but spiritual, psychological symptoms, existential questions that patients and family members have as they absorb the shock of a diagnosis of a terminal illness and begin to process that, and as they march through what is a terrible journey to their death, they begin to have as many physical symptoms. And we begin dealing with 5 different key domains as we take care of our patients. Palliative care has a number of mandates to it. It's the relief of suffering and the affirmation of life. Palliative medicine is not meant to hasten or speed death, nor is it meant to prevent death. It's really meant to offer symptom management to patients in a systematic, multidisciplinary way. This is not a single nurse providing care. This is not a single physician. It's a team of medical providers who can provide the very best end-of-life care and who can relieve suffering in the best way. Those team goals address a number of the domains in our definition, certainly symptom management and pain and physical symptoms being very important, but addressing goals of care, understanding the preferences of the patient before they're unable to provide their own preferences themselves, providing information, coordinating care, and recognizing that the psychosocial support of the entire family unit is paramount. This is active care. We often will encounter physicians who at some point in the journey of a terminally ill patient will say there's nothing else that we can do. And that's absolutely the wrong thing to say. Obviously, there's always something that we can do. And I think providers often misspeak when they say there's nothing that we can do. Perhaps there's nothing that we can do to stop the inevitable progression of a terminal illness, but we can always take care of our patients in an active manner that improves their quality of life. And that importantly recognizes dying as a normal process. And I don't know what the students of Cameroon have experienced, but in the United States, we get very few lectures on the normal process of death. We spend most of our time talking about pathophysiology from a conceptual framework that we can treat the pathophysiologic process. But sometimes you simply can't treat the pathophysiologic process, and we're all going to die. If this is news to the students of Cameroon, it's going to happen to each of you. It will obviously to me as well. And recognizing that death is a normal process and managing the stepwise decline of the dying patient in a way that affirms their dignity and gives them the highest quality of life should be a goal. But unfortunately, in the United States, we don't teach that stepwise progression of death. We spend very, very little time in our curriculum talking about death as a normal process and helping students realize their role in caring for the dying patient. So there's a mismatch of patient expectations. Patients and families expect that physicians are competent in understanding death and facilitating a good death, in facilitating the relief of suffering, in facilitating a patient being able to have their preferences met at the end of life. But because we have very little curriculum devoted to the normal pathophysiology of death and dying, our physician providers are generally ill-prepared to provide that level of service to patients and families who expect that they're competent and skilled in understanding death. In emergency medicine, we take that a step further because we've trained an entire generation of emergency physicians to recognize that death is failure. Our goal in emergency medicine is to prevent limb or life loss. That is our goal. It is to recognize the immediate threats to life and limb and to do interventions to intervene in ways that we can prevent those processes from happening. If there is a tension pneumothorax, we put in a chest tube, right? If there is ventricular fibrillation, we defibrillate ventricular fibrillation. And this is how we're trained. We're trained to avoid death. But when death is imminent and death is normal and natural, we become very uncomfortable. We have not been trained as a specialty to recognize when death is inevitable and help to facilitate that good death. We instead generally try intervention after intervention after intervention until we have lost, until the scenario is not won, until the scenario is a failure. And that death equaling failure prevents many emergency physicians from authentically looking at death as a normal process and trying to teach themselves how to better care for patients who are going through a dying experience. So therefore, care comes far too late. We recognize death and dying well into the death and dying process, way downstream after we probably already should have recognized that the pathophysiologic process of dying has occurred. And in the United States, we have a really key marker for exposing just how poorly our providers recognize death. We have the hospice program. In the United States, hospice is a benefit of the government. We pay taxes our entire adult life, employment taxes, into a system called Medicare. And the Medicare system provides healthcare services to the poor or elderly in our society, just to make it very simple, but also provides an end-of-life benefit called hospice. And hospice is supposed to be available for patients who are in the last 6 months of their lives. If a physician looks at a cancer patient or a terminally ill emphysema patient or terminally ill heart failure patient and says this patient really only has 6 months left to live, they can enact the hospice benefit, this government benefit for patients. And once that's enacted, then patients can be placed into the hospice system, and that system can begin to identify special care needs that they may have, and as in my mother's case, ratchet those treatment protocols up and up and up at the end of life. So for my mom, as I said, we were able to get a hospital bed in our home and all sorts of different medications and eventually care providers that checked in on her once or twice a day, all the way up to 24-hour nursing for the last couple of weeks. Excuse me. That's because someone identified that she was dying and got the benefit started. In the United States, the average length of hospice care is 2 weeks for something that could benefit patients for the last 6 months of their life. That's a huge red flag to me that our system is broken, that our providers are ill-trained, that they're ignoring the data points in front of them because they can't lose. They don't want to let the patient go. They can't have the difficult conversations with patients and families to help them understand when death is a pending problem in the coming months, if not imminent in the coming days. And this is a training issue in the United States. So we're moving from the top bar to the bottom bar in terms of a paradigm shift in the United States. In the top bar, you can see from the purple line, this is the time of diagnosis of a terminal illness. And if you take cancer, for instance, let's say this is colon cancer, that the colon cancer is diagnosed at the top, at the far end of the tan bar there with the purple hashtags. And the x-axis is time, and for a period of time, all we do is treat the cancer. And we treat the cancer with chemo, and we treat the cancer with surgery, and we treat the cancer with radiation, and then that chemo fails, and there's a new trial of chemo, and then there's another trial of chemo. In the United States, the National Cancer Institute sponsors special studies for experimental drugs, and we might try one of those. But eventually, we give up, and we say, there's nothing more that we can do for your cancer. You are dying, and the curative portion of your treatment has ended. Now let's begin the Medicare hospice benefit, and at the final purple line, you die. This is the old paradigm, and by old, I mean maybe 15 years ago, this is how it went for everybody. And we should be moving to the bottom paradigm, which still, despite all of the education being done by groups such as EPIC-EM and our friends who are specialists in palliative care, that first paradigm still continues today for many, many patients. This is a common experience of dying patients in the United States. But the bottom paradigm is where we should be. We should recognize that at the time of diagnosis, there are some minimal palliative care needs of a patient. They may be pain, they may be psychosocial support, existential crises that occur when you're given a terminal illness, a terminal diagnosis. And for a while, the majority of your care should be aimed at cure. So obviously, taking out the tumor and irradiating the tumor and giving chemotherapy, these are potentially curative interventions. And that should, for a while, be what we spend most of our effort on. But as we begin to lose the game, as the patient gets chemo trial after chemo trial and simply doesn't improve, you can imagine that their palliative care needs increase. Their symptom burden, even beyond pain, but terminal delirium, terminal nausea, wound care, all become much more important. And we earlier enact a hospice benefit. Note that the line representing hospice shifts because we start to recognize the data points in front of us and recognize that death is coming. And we're able to shift out of a curative intervention mode and into one that's meant to treat patients with respect and dignity, and give them a higher quality of life for many more months before their death. And then after death, we recognize that families have bereavement needs, and we have to take care of the family unit as well. That should be the new paradigm. And I've been giving this lecture for 15 years, hoping that that paradigm shift would become universal in the United States, and we just aren't there yet. I think that the problems with our medical school and residency curricula are such that we still have a lot of physician providers in the United States slogging patients in the top, according to the top paradigm. So let me tell